Hi, good afternoon, everyone. Thanks for joining us today for a webinar on the topic of pelvic mesh and Morcellator use in gynecological surgery. My name is Michael Morgenstern. I'm the head of marketing at the Expert Institute. Today we are joined by Dr. William Porter, a fellow of the American College of Obstetrics and Gynecology and board certified in his field. Over Dr. Porter's 10+ years of practice, he has been appointed to academic and clinical positions in obstetrics and gynecology and has pursued numerous high-profile grant research endeavors. Dr. Porter currently practices in Charlotte, North Carolina, and today's webinar will run for about 60 minutes and will be followed by a 10-minute Q&A. You can type your questions into the question window on your control panel, and Dr. Porter will answer verbally. Thanks again for attending, and please welcome Dr. Porter.
All right, hello everyone, good afternoon. I'll go ahead and get started. All right, hello everyone, good afternoon. Go ahead and get started with the discussion of the day. As Michael was saying, I am Dr. William Porter. I am a practicing physician here in Charlotte, North Carolina. I have a subspecialty training in female pelvic medicine and reconstructive surgery, or some may know it as urogynecology. I've done a 3-year fellowship within that field and have been practicing exclusively urogynecology for the last 12+ years. I'll go ahead and limit our talk to a couple of different hot topics today. One's kind of on the tail end, and one's kind of going into more of the mainstream. One would be uterine morcellation. We're going to tackle that first. The why we do uterine morcellation, why the morcellator was or is in use in practice, and the difficulties of using the uterine morcellator. I'll also head on pelvic floor mesh as well as slings and kind of go over that topic as well. So kind of get a various, two different varied subjects. One a little bit more technical, the uterine morcellation. I think it's very key to understand the morcellator. It's not such a clear-cut issue in practice of medicine. There is reasons why we morcellate, and we'll kind of go through that as well. So let's go ahead and get started. Again, first one is uterine morcellation. Uterine morcellators have been around for quite a long period of time, since 1993, so about 22, 23+ years. It was really developed to reduce the amount of solid tissue specimen into smaller pieces, and this allows it to be extracted through laparoscopy. So in a nutshell, we are making smaller incisions on the patient's abdomen in order to remove a larger mass. Otherwise, that we'd have to make a large abdominal incision. So that's the kind of why morcellators are used, in order to make our surgery less invasive to the patients. You can tell there's some studies out here that showed definitely a 53-minute reduction in time during surgery versus making a larger incision. Again, the other benefits of why we use a uterine morcellator or morcellation of tissue, decrease the risk of infection, blood loss, and any sort of blood clotting diseases. As usual, the gynecologists, initially rapidly adopted this technology because the prevalence of uterine fibroids, obviously, this is why I'm talking about this, because of the risk of uterine sarcoma and the spread of that disease with the uterine morcellator. Fibroids are very common in society. 40 to 60% of people will have some sort of uterine fibroids. Again, once the gynecologists adopt this technology, it's been also adopted by other specialties within the system, so general surgery as well as urologists, in order to get their specimens out. So again, kidney or spleen issues. Again, benign uterine fibroids are the most common pelvic tumor in females. Again, up to 70% in white females and 80% in black females. So very common out there, so that's why it's a very useful apparatus. However, when we talk about uterine sarcoma, is a very rare disease. It's only 3 to 7 per 100,000 people in the United States. However, if you do have the disease, it's a very devastating cancer, and there's really very poor cure rates. So that's why it's concerning, but it's not very common at the same time. So that's one of the things that we have to definitely discuss here, the reasons for this. The United States insurance database, about 232 cases were done laparoscopically, either laparoscopic or robotically. Hysterectomies were performed, and Morcellators were used in roughly 15% of those. So you can see right there, usually of the 230,000 hysterectomies, 15% had to be morcellated in order to remove it from the abdominal tissue or abdominal cavity. So it's pretty common. We've used quite a bit of those a year. So if you look at 36,000, that's a significant number of cases per year. However, among the women who had morcellation, there were about 99 cases of uterine cancer. So it's still not very common, about 1 in 370. 39 had some sort of uterine neoplasm of uncertain malignant potential. That's kind of a diagnosis where I'm not quite sure what that means. It's not, could be cancer, it's borderline, it may not be cancer. And 368 cases of endometrial hyperplasia, which is could lead to cancer, but it's not cancerous at the time of diagnosis. So essentially, the uteruses need to be removed one way or the other. Otherwise, there's been 26 other gynecological malignancies that were not part of the uterus. So that could be fallopian tubes or ovarian cancer that were diagnosed at the same time. Again, the prevalence of malignancy was 0.34%, and of all neoplastic conditions, 1.5%. Again, not very common, pretty rare, surgical uterine sarcomas. However, there are some risk factors. I'll give relative risk of cancer versus women of age 40. So all these age groups here, as you can see, going from 50 to 54, 55 to 59, as you see, there's an increase with age. So obviously, just like most cancers, the older you get, the more likely it could be cancer. So again, increased risk with age. The prevalence of cancer in a serious woman under age 40 was pretty rare, 1 in 1,500, and women from 40 to 44 is 1 in 1,100. Again, you can see much more common as you get older. I got the risk factors for sarcoma, black females, increasing age, and postmenopausal status. So people who postmenopausal, that also is a risk factor, independent risk factor. That can also be related to age. Previous tamoxifen use, we use tamoxifen currently for treatment of breast cancer. Tamoxifen has a negative effect on the breast tissue, however, it has a positive effect upon uterine tissue. That's the reason some people will get uterine cancers from tamoxifen use. Any sort of previous pelvic irradiation, some sort of previous cancer treatment or for cervical cancer or whatnot, or whatever it may be, any sort of radiation they've had in the pelvis can also be a risk factor for sarcoma. Previous kidney cancers, childhood retinoblastoma, not very common again, and again, hereditary leiomyomatosis, which is this kind of a multiple soft tissue or smooth muscle cancer, or not smooth muscle tumor disease of the pelvic, as well as abdominal cavities. Not very common, but it is out there, can be had. Again, the problem with sarcoma, we need a tissue diagnosis. And that's the problem as we treat these patients with fibroids and try to reduce their risk of more invasive surgery. We don't really know they would have cancer until you get a histological or some sort of pathology. You get not necessarily a biopsy, but you actually remove the organ in order to determine if they have cancer or not. So it needs some sort of pathology in order to determine if they have cancer or not. There is no great imaging that can help predict cancer, sarcomas especially. So ultrasound, MRI, PET scans, CT scans, those are not very useful in determining a cancerous fibroid versus a benign fibroid. Again, frozen section. Frozen sections is something that we can do at the time of surgery. We'll send a specimen down to the pathologist and have them look at it, and they'll do slices of that tissue and they can identify if it's cancerous or not. However, most of the time they're, it's not very accurate. Well, why does it matter? Why are we talking about this today? Really kind of started not that long ago, a couple years ago, with a plight of Dr. Amy Reed. She's a mother of 6 and a Boston physician who speaks of her personal experience with spreading of her cancer. She had I think it was for uterine fibroids, and they went in, took the uterus out through laparoscopic surgery, and she developed, she had uterine sarcoma, and her belief is that the use of the Morcellator spread that cancer throughout her abdomen. So her and her husband, who I think is either a radiologist or some other physician in Boston, kind of have started this kind of like, hey, let's get rid of the Morcellators and go from there. So that's how we really got interested in this. If the manufacturer's failure to warn, the clinicians or the patients, is there some sort of risk to using their device? So that's why it really matters. And there's people that we are concerned about. So we're going to go talk about this at this point. Why it matters. Morcellation of uterine sarcoma is associated with a worse prognosis. So we know that if the uterus was morcellated either by a power morcellation, which is the manufacturers that we kind of talked about, or even a scalpel morcellation, does that increase their prognosis or worsen their prognosis of their cancer? There's very little data out there, very, very few studies that actually you can look at the difference between when we just take a knife and make it smaller to remove it through the smaller incisions versus taking a power morcellator where we kind of grind it up. So it really, for the unknown, we don't know if there's a lot of what this really means, if there would be a difference if we kind of removed it with a knife or removed it with the power morcellator. Again, there's been one study out there that showed that uterine leiomyosarcoma apparently combines with the uterus at the time of surgery. Again, 25 women. It's not a huge number, but at the same time, there's not a huge number of people that are diagnosed with this cancer each year. Again, morcellation was associated with a significant decrease in 5-year disease-free survival. So what that really is kind of stating that morcellation will worsen your prognosis as well as decrease your ability to survive at 5 years. Again, another study kind of looked at the disease confined between the uterus, morcellation versus not. Again, there is as you can tell with this overall slide, there's definitely increases your disease spreading ability, decreases your survival time if you had it morcellated at the time of removal. So that's concerning right there. So that's why we're talking about this again. Again, risk of morcellators by themselves. So they have individual risk outside of splenic cancer. Risk of injury from like sharp tools. So meaning that you're putting this blender, grinder device into a 10 millimeter or roughly ½ inch port, and you could injure the bowel, you could injure a blood vessel or any other surrounding organ. So there's risk of that in the cell. So again, it's not just spreading cancers with other things that can happen with a morcellator. The MAW database, which some of you may be familiar with, which is a self-reporting government website that looks at complications. Not very accurate, it's definitely underreported, but it is one of the few things that we can kind of look at. Again, 55 injuries between 1993 and 2013. I mean, that's pretty low. I know of a couple just at my own hospital alone, within that time period. So it doesn't seem very accurate across the country. Again, bowel injury, bladder injury, blood vessel injuries, any sort of thing. Complication rate, again, 0.02 to 0.007%, assuming some 25 to 70,000 cases a year. In July 2014, the FDA convened a public meeting. Again, we're talking about this. November 2014, the FDA safety communication. It's kind of like a warning level, just like we talk about later with the mesh product. It's something's happening here. Laparoscopic power morcellators are contraindicated for removal of uterine tissues containing suspected fibroids in patients who are peri or postmenopausal or candidates for in-block tissue removal. Okay. The problem with that statement is this is everybody that you would morcellate. So the FDA is saying that it's contraindicated now for patients that we'd actually use a morcellator for. I mean, we're using this to get rid of, fibroids, patients who are usually perimenopausal, postmenopausal. So pretty much the FDA is saying that you really can't use this device. Laparoscopic power morcellators are contraindicated in gynecological surgery, which tissue to be morcellated is known to be or suspected to have cancer. That's kind of a no-brainer. Obviously, we wouldn't do that, but that's the FDA statement. They go on to say that the FDA warns that uterine tissue may contain unsuspected cancer, which, that's one of the things. Did we understand that in the past? Is that something that should have been warned about in the past? And it said may spread cancer and decrease the long-term survival of patients. And based on some of the studies we looked at earlier, it has been shown to worsen your prognosis. And they said that you should counsel your patients and share this information with your patients. Carefully consider all the other treatments. Pretty basic information there. And just thoroughly discuss the benefits and risks of the treatments with all the patients. Be certain to inform all patients about the risk of laparoscopic power morcellation and what may be acceptable to the patient and what not be acceptable. So those are pretty much talking about informed consent. And make sure that the patients have informed consent. As anything that we should do, again, just like mesh, we need to be having informed consent. Were the doctors properly informed about these risks? Were the patients properly informed about the risks? And that's really what the FDA is kind of discussing here, is make sure that this information is disseminated to the potential users of this device. However, ACOG has a little bit of a counter statement to that. So the American College of Ob-Gyn has some statements in support of the Morcellator. They say power morcellator has a role in gynecological surgery. Power morcellator can make it possible for some women to then go to less invasive laparoscopic surgery. So instead of making a big abdominal surgery because of the size of the fibroids, the power morcellator allows you to have a quicker recovery, less invasive surgery. So so we have some competing thoughts of why the power morcellator should be or could be used. Decrease recovery time, decrease the mortality rate. And we're going to talk. I have a telltale sign or a slide later talking about that. Deliberate patient selection, however, should be with an informed consent. So that's one thing that probably has been lacking in the past. Is really patients really were not adequately consented about the risk of possible spread if they have an underlying cancer. Again, they want to go on to clarify a specific definition of perimenopausal woman. As I mentioned earlier, the FDA said pretty much if you're perimenopausal and fibroids, the Morcellator is contraindicated. The AAA, the American Association of Gynecological Laparoscopists, have a kind of a different statement. They really want to make sure that what that really means. They really want to define what perimenopausal, who's are candidates. I think that the problem with the FDA statement is too broad, where the AAGL want to kind of redefine that. Again, the AAGL has stated there's a role of power morcellation in reproductive age women as well as perimenopausal women. It allows fertility-sparing surgery. So when people who have fibroids and have infertility, we go in and remove the fibroids and allow fertility to occur, allow them to get pregnant. So that's taking this option would involve more invasive surgery, like abdominal surgery. Again, patients who do not have fibroids, who just have refractory bleeding or prolapse, the Morcellator should still be allowed to be used. Again, talk about containment bag, talk about that a little bit later, some things that we can do to prevent maybe the possible spread of the cancer. All right. Abandoning power morcellation technology for many patients undergoing these surgeries would be a setback. So, they have a couple of AAGL as well as ACOG have some strong statements against completely disbanding or not disbanding, but actually banning of the power morcellation treatment. So there's going to be some people on both sides of the aisle saying that there's some things you could do to kind of prevent these, either spread of the cancer or maybe we can even, try to do better prediction of cancer. But again, nothing's 100%. Really kind of look at these guidelines and see if we can follow these to help prevent, patients having bad outcomes. Again, they think the benefits of a power morcellation outweigh any risk of a laparotomy or risk of cancer in these patients. So that's what, there are really some strong statements by the AGL out there. What are the alternatives to power morcellation? So, what you guys are considering power morcellation is really power morcellation. So, other things we've been doing for a long time, obviously, is the open hysterectomy. That's been around for a while. We have to make a bigger incision and remove some of these large fibroids. Manual morcellation, so that's where instead of taking a power morcellator, and grinding the tissue up, we actually take a scalpel and carve out pieces, right? Just like you would if you, carve a piece of meat. So in order to get that out to a smaller incision, we might take smaller pieces out piece by piece. Vaginal coring is the same thing, but we do it vaginally versus abdominally. Or what AAGL was talking about is doing a power morcellation through a contained bag. So putting the specimen inside a bag laparoscopically and then inserting the morcellator within that bag to remove the specimen. There's some risk associated with that. That may increase risk of visualization, maybe injuring different parts of the body. So none of these are all additional risks or different risks. Maybe not spreading the cancer so much, but maybe there's also other risks that are associated with these other treatments. This is an interesting study by Dr. Naumann. He's actually in Charlotte, but he was presented at a national meeting. Showed that mortality from a laparoscopic hysterectomy with morcellation, even accounting for possible dissemination of the cancer. Now, he's a gynecologist, so again, as I said earlier, uterine sarcomas are pretty rare. It's still less than the mortality rate from abdominal hysterectomy. So this is saying, if you're even considering the fact that doing a power morcellation of a cancerous uterus, if you look at the overall numbers, and this is where the actuary kind of really comes into place, I know as a person you don't want that kind of statement to be said, but in practicing good medicine, sometimes we have to look at the overall benefits and risk of a surgery. So there's a higher risk of mortality from doing abdominal hysterectomy in all these people versus actually doing a power morcellation and the risk of cancer spread. So that's kind of the caveat of, and it's not such a straightforward and cut and dry picture when you look at power morcellation. There's a lot into it, and that's going to be some of the nuances to defend against or prosecute against when you go about power morcellation. So I think it's not such a straight answer, and that's where it's going to be, you necessarily look at each individual kind of patient or client. Again, if all the laparoscopic hysterectomies were converted to an open hysterectomy, 17 more would die each year. Okay, so that's something that I have to look at. Again, the sheer number of people actually had uterine sarcomas, that's kind of a telltale sign that maybe it's not such an easy answer to kind of come up with. Again, summary and recommendations for the power morcellator. Benign uterine fibroids are the most common pelvic tumor. Again, 78% of females will have some sort of fibroids in their lifetime. Uterine sarcoma is a rare occurrence, 3 to 7 per 100,000. This will increase with numbers up to like 1 in 300, 1 in 500 the FDA is quoting, only in patients that have, large fibroids. It's kind of a different, we're looking at different numbers. You can't compare apples to oranges. The likelihood of finding a sarcoma in a population of women with an intrauterine mass is approximately 0.1 to 0.28%. So pretty, not huge numbers, but they're significant numbers. Clinical manifestations are not useful to distinguish between benign tumors and cancers. So that's the problem that we're having at the time. It's why we need that pathological. That's why we need a specimen in order to diagnose cancer. So it's hard for doctors to predict, so there's really nothing for us to go by at the time of surgery. There's nothing to say, okay, you have cancer, we have to change the type of surgery. Some of the recommendations otherwise, rapid enlarging uterus is not a reliable sign. That's something I was taught in residency, and people before me and afterward taught that, hey, this could be a reason why you look for sarcoma, something rapidly enlarging. After menopause, on the other hand, a new or growing uterine mass warrants further evaluation. So that's where, if you have postmenopausal women, they have a growing mass, that patient might be a higher risk for, uterine sarcoma. You should maybe not do power morcellating those people. Again, postmenopausal women on hormone therapy may increase their size. That's something that's also considered when you're, postmenopausal women. And large uterine size in excess of 20 centimeters has not been shown to be associated with increased uterine sarcoma risk. So again, large masses are not necessarily associated with it. So we're really up in the air in having reliable predictors for cancers. And so I think the biggest issue is we don't really know, based on their history, if they have cancer or not. Sampling the uterus ahead of time may detect cancer, but again, it's not an absolute. Again, there's no great pelvic imaging that can really help us in determining what may be cancer, what may not be cancer. All righty. Again, the MRI may be helpful. Again, not very good data. Counseling women is probably the most important message of the day. However, in my practice or in my hospital system here, they have banned uterine morcellators altogether because the FDA has come up with such stringent criteria to meet with training of the physicians, training of the staff, and upkeep of the equipment that the decision was made by executives looking at liability that we are no longer powered morcellate. So again, they have some criteria. They said it shouldn't be gone away, but I think it can be almost into referral centers that they can still be able to do power morcellation. Any surgical technique that disrupt the uterine specimen, scalp, or power morcellation. So again, should not be performed in women who are known or suspected cancer. So again, obviously shouldn't operate and take away part of the uterus out. People might think they have cancer. Again, recommendation not using power morcellation for uterine tissue for women who have significant risk factors. Okay? Again, our risk factors are very poor. We don't really exactly know, but again, tamoxifen therapy, postnatal status, irradiation, childhood, eye cancer, childhood, kidney cancer, those sort of things would be risk factors. Those something in the history you maybe should avoid due to power morcellators in that. So there's some other recommendations. Again, really kind of the scope. This might even be point across the country. The power morcellators may be taken out of the physician's hands just based on the liability, out there in hospital systems. But really, most of the, any use of power morcellation at this point forward has to be thoroughly consented. Again, that's some of the issues in the past where this patient is thoroughly consented. That's really what the point of the AAGL statement, the ACOG statement, where the FDA is pretty more of a blanket statement, almost saying that we should get rid of this black box warning and, stop using the device. Okay. Again, some other basic things you're talking about here. Fibroids usually not, progress cancers. Very rare that they ever would do that. No great thing, maybe some uterine samples, the uterine biopsy done prior to that with an MRI could be predictive factors, but they're not an absolute. Again, there's no great tools that we have ahead of time to predict cancer. All right, so we're going to move on to the vaginal mesh, which we'll talk about briefly, and then we'll get into some question and answer period. Again, why was mesh developed? And not all mesh is created equal. Kind of got to go with both of those things. Why we developed vaginal mesh for prolapse repair, low success with traditional repairs, as well as decrease the reoperation rates. So we have to look at balance the factors of the mesh is developed to increase our success rates. Maybe you have less reoperation, less failure rates. That way, patients not going under anesthesia again. Again, not all the mesh is created equal. You can look at an Ob-tape, which is versus a very small, mini arc. They're treating the same thing, but again, they're the same material, but not quite the same. They have some other issues. So I'm going to kind of go over all those things with you and kind of go from there. Again, there's 3 different types of polypropylene, type 1, type 2, type 3, I'm sorry, not polypropylene, but of mesh characteristics. Usually polypropylene would be a monofilament, macropores, greater than 75 microns. The reason that's important, it allows the bacteria to be cleared by the white blood cells. You need something that's large enough that allows the white blood cells to get into the mesh to kind of clear any sort of underlying infection. Otherwise, you look at the Ob-tape, which is another mesh out there, that was a tighter weave, and even though it's polypropylene, it was made a little bit differently. It was woven in that weave, or vice versa, again, but it was very small pores. Again, then if you look at type 2, that would be Gore-Tex mesh. Again, that's multifilament, is much tighter, tighter weave or tighter, you can allow bacteria to stay on it. There's some great studies from the 90s looking at Gore-Tex slings, which had horrendous problems with erosion. So definitely some data out there. And then you look at type 3, again, it's polypropylene, IVS, tunneler, macropores, as well as micropores have a combination of both of those. So there's some other, not all meshes are the same, so that's why each one may be a little bit different. Here are some women health initiative study, which kind of shows the type of prolapse out there. Again, 41% of having prolapse in your lifetime, 11% chance of having surgery, and about 30% chance of having surgery again if once you fail. So that's why the mesh was developed. If you look at the bladder prolapse, cystocele, rectocele, as well as the top of the vagina prolapsing. So that's really why we're trying to increase our success rates, decrease the morbidity rates of the patients. That's really why we kind of started developing mesh products. Again, basic routes, basic surgery for prolapse. You can do the vaginal route, which could be an anterior repair, posterior repair, vaginal repair, whatever it may be. That can be done with or without mesh. Okay, you can attach it to a ligament again. Or you can do a abdominal route where we do a sacrocolpopexy, which is used with mesh a different way. So it's not necessarily placed vaginally, but it's placed abdominally. And there's a New England Journal article about a year or so ago now saying that that is not as good as we thought it was either. So there's some problems with placing mesh abdominally, not only vaginally. So there's, again, we're doing this all to make our success rates better, but there's been some bad outcomes that have occurred from using mesh as well. Again, you look at some studies supporting mesh. We have mesh erosion rates here ranging from 5 to 20%. So success rates, again, 80 to 90%. We can kind of see some studies here based on this. However, the follow-up is pretty short too. It's not great long-term follow-up, but surgical data, we usually don't have a lot of great long-term follow-up. Again, failure rates, recurrence rates, they can occur if you do a standard suture repair. Again, 45, 50%, pretty common, pretty typical in the anterior compartment. So that's why mesh is developed. However, mesh does have its issues, and I think we know about those. There's some basic kits. The newer versions of these mesh kits kind of look like the one on the left. Less mesh, smaller size, wider weave, lighter weight. Some of these companies have gone into trying to develop, things that we may think that are risk factors for having bad mesh outcomes. So they've gone into a smaller piece as well as, a little less mesh, a little dense mesh, a little wider weave, less size of the mesh. So the original mesh, first generation mesh, kind of looks the one on the right. There's a couple different renditions of this by different companies. They all look very similar to this. But again, it's a much bigger piece. It's a monster piece. A lot of mesh arms in there, a lot of bunching of that mesh, a lot of contraction, a lot of rolling that mesh can occur. So definitely have some problems with it. Again, if you look at this, this is kind of how the mesh would sit inside the body. The arcus tenoneus, you can look at the sacrospinous ligaments, you can kind of see where the mesh actually sits. Sometimes that mesh became detached. It allows it to kind of roll or contract, and those are points, especially the sacrospinous ligaments, points of contracture that cause pain. So those are kind of really why patients would have pain with intercourse. Essentially, it's the back wall, so with intercourse, patients would hit that, and that's why they had reproduced pain, because it's intimately involved with the pelvic floor. Again, transvaginal mesh versus abdominal mesh, we talked about that earlier. The advantages of vaginal mesh, you don't get inside the abdominal cavity. The newer mesh erosion rates have dropped down significantly from the 15% up to 29% that we saw with the first generation mesh down to 1 to 4%. Failure rates are still better. However, most people with problem mesh are some of the early generation mesh. Abdominal mesh by itself is not without complications. Erosion rates, again, are going to be about 5%. It's not as bad as some of the first generation mesh, but there are some issues out there. It works a little bit differently, it acts a little bit differently. The vagina becomes less fixed, but you can definitely have some problems with sacrocolpopexy mesh as well. Again, we're going to go over sling options, and then we'll get to the question period here. So again, there's different types of slings. They're not all the same. I left out something called a prefix sling, which is a prepubic sling, which is a short-lived sling out there made by Boston Scientific, but I don't think too many were placed in there, so there's a high failure rate. But retropubic obviously goes behind the pubic bone. The transobturator, the TOT sling, goes to the obturator canal there. You can see how it comes out. And then you have the newer version, the mini sling, which are kind of like a TOT type sling. Again, over time, they've gone smaller, as well as some of them gone to a lighter sling, but really trying to leave less mesh in the body to kind of overcome some of the problems they've had with mesh in the past. Okay, the OGS, American Gynecological Society, as well as Society of Urodynamics and Female Urology, SUFU, have come out with position statements, and we, I've done several depositions, and they always bring this up. How the position is made of slings, if you agree or not agree. Polypropylene mesh mid-urethral sling is a recognized worldwide standard of care for the surgical treatment of stress urinary incontinence. So they have, really two big societies dealing with incontinence, and have come out with that statement. It has provided safe, effective, and has improved the quality of life of millions of people. That is correct. I mean, those things are out there. Some pretty strong statements, again, by the medical societies. So it's something to consider for your clients. The FDA came out in 2011. The safety and effectiveness of multi-incision slings is well established in clinical trials that follow patients for up to 1 year. So this is a little bit different than the FDA statement of 2008 that they stated that they were unsure about slings, but in 2011 they really say slings are not necessarily an issue with the mesh part. So there's really some nuances of that. It's really, again, getting back to informed consent about to the patients. But the FDA has kind of backed off their statement in 2011 about slings. OGS and SUFU also come out with polypropylene material safe and effective as a surgical implant. As a knitted material, polypropylene mesh is a consensus graft material for augmenting hernia repairs. So it's taking some data from non-gynecological sources and adding that to and incorporate it into their thoughts of why we use polypropylene. Again, safety up to 17 years, so they have some follow-up again as well. The monofilament polypropylene mesh mid-urethral slings is the most extensively studied anti-incontinence procedure in history. That's probably correct. This is one of the first branded products made by companies. Before, they were all some sort of technique developed by some sort of surgeon that had poor outcomes. It's greater than 2,000 publications out there in the literature. So there's some great data, and you can probably find, your whatever you may believe on both sides of the table. So there's good data supporting, slings, and there's data against slings. Just like any problem, there's data on both sides. And again, they kind of talk about the history of incontinence surgery, saying over 100 surgical procedures have been developed, and the mid-urethral sling has been shown to be the most effective with the least amount of problems. Again, more than 3 million people have had it placed worldwide. We get back to the original statement, not all the slings are made the same, so that's something else you have to consider. And each one has its own properties. Each company has their own properties of their mesh, so they might be not necessarily the same. But there's data out there supporting the use of slings. In conclusion of polypropylene slings, the mid-urethral sling has helped millions of women with stress incontinence. Okay, that's what OGS is saying. The safety and efficacy has been out there. In the past, we've had concerns of more invasive surgery, abdominal surgeries. So this is definitely less invasive, a little bit quicker, easy recovery time. One of the unintended consequences of the polypropylene mesh constantly has been to keep women from receiving any treatment. So they're really kind of coming after, some of the misstatements about slings out there. So I think that's kind of where you have some strong opinions by certain people in societies. Again, this is probably the most important advancement. This is from the OGS and SUFU statement. These are pretty strong statements that have some well-respected individuals in the society. That is true. Most of this is true. However, there's some, obviously some problems of certain products and certain people. So patients definitely have some issues with mid-urethral slings. Facts and myths. Mesh weight, it does play a role. And if they doubt that and they're in any sort of meetings, why have they changed the mesh over time to a lighter mesh? So that does play a role. There's some bad data out there, especially with Optape. They've kind of skewed their numbers a certain way. I just know that off the back of my hand. There's some misconceptions about during depositions to bring out this is not meant for human use. There's ways around that statement. There's ways for that statement. There's different ways, and it's pretty much how you want to play that. The warnings that the line companies who make the polypropylene mesh, they want to more the CYA more anything else. I think that's just not. We use polypropylene for years, so I think there's some misgivings about that actual statement. Some data suppression. I know that's been out there. That some bad data, not just for slings but mesh. Talking about that, trying to withhold the data out there from public consumption. Again, the mesh contraction, shrinkage, rolling. I know we've come up with different terms because it all mean the same. It's really hard to differentiate any of those issues on exam. We need a pathological diagnosis to really kind of, to me, they all mean almost the same. I mean, it's really, to get the nuances of each of those, you really can't tell on examination. That's more of a diagnosis of removing the mesh. The problem also with mixed incontinence, people think that there's, slings cause problems because they either one, they develop overactive bladder, which can happen, or two, they solve their overactive bladder. Slings aren't meant for that. So I think there's some misconceptions by the public, maybe the doctors, that they really were not informedly, have great informed consent. And then again, we know surgical failures do exist. At least 15% failure rates for slings, 15% failure rates of mesh products as well. Here's a common erosion of the mesh in the posterior compartment. That is the posterior vaginal wall. This is what you would see quite often with the mesh. Then we call it, I guess, a mesh exposure, not an erosion, because it's not into a hollow organ. And then, so that is what we kind of see, some how to treat that in the past. We gave some local estrogen. That's such a large piece of area that's not going to heal up with local estrogen. You actually have to cut that out and excise it, and I would do that size in the operating room. Again, other things for dispruning or painful intercourse, chronic pain, there's pelvic physical therapy. People should try trigger point injections, revise and revision of that mesh, cut it out, removing the whole mesh. That definitely is almost impossible to do. It can be done with a very invasive surgery, not usually recommended as a first-line therapy. Again, urinary retention after incontinence surgery, repeat voiding trials, those sort of things. Consider treating, ISC. Persistent retention, again, people worry about slings can definitely cause long-term retention if they're not treated early and appropriately. That could be a problem of more of a malpractice than actually a problem with the product. Again, how did we get here? Again, we try to develop a better product to solve incontinence that we've been struggling with for years, as well as prolapse. Again, mesh is not as bad as it seems in the past. I mean, there's things that, mesh is good, but it's not great. And there's problems, definitely problems with it. Again, mesh is not as good as we thought. Too many people put in the wrong patients. I mean, there's definitely problems that can happen with mesh. So there's kind of a fine balance between the two of those. And the biggest problem is too many inadequately trained physicians put mesh into the wrong patients. Again, I see this all my time with patients who are coming to me who have mesh problems. Again, they weren't either properly consented, they have the wrong diagnosis, they have the wrong issues, too young, too sexually active, previous pelvic pain. Those patients aren't mesh candidates, but they put it in there, and I think in the end, we only develop problems with the product. All right, that kind of concludes the run through the morcellators as well as the mesh talk, and we're going to go ahead and ask for any questions out there. And let's see. trying to see if there's any questions. All right. Is bladder perforation a risk of TOT for stress incontinence? What factors may indicate a failure to conform to standard care where perforation occurs? Yeah, so there is risk of bladder perforation with a TOT. That's why we do recommend that all patients should have a cystoscopy done concurrently with any sling, not just retropubic slings, not just with mini slings, but any sling. A cystoscopy should be performed in order to identify any sort of perforation. So, to me, the standard care would be doing a cystoscopy on all slings. So that can occur. It does occur not as often as with a retropubic sling, but TOT sling can have a perforation. So obviously, if what doesn't standard of care, if they didn't actually, cysto, that to me that'd be deviation of standard of care. If they didn't identify the perforation at the time of surgery, if you did perforate with a transoperator sling, you may want to not complete that sling for the day. You may have to leave it out and let it heal. So that would be kind of my answer for that. Let's see. Let's go from the beginning here. We have a few questions. Any chance to get a copy of the PowerPoint? Yes, we could make that available through, with Expert Institute. I represent a man who, oops, sorry. I represent a man who underwent a prostate procedure utilizing a Morcellator. His procedure was terminated when it was discovered that he had taken on 22 liters of fluid through a puncture of his prostate. How is fluid and outtake monitored by whom? The fluid should be, there should be a, at least with the, the uterine manipulators, uterine for doing hysteroscopy, the fluid should be monitored by a bag, and that should be monitored by a fluid management system. This also should be monitored by the nurse and as well as the physician. So that should be something that they should be looking at, more of a malpractice case itself versus anything else, but that should be monitored by both the nurse as well as the physician. They should be indicating that they have a hole someplace. So that should be something looked into, that they should be able to do a fluid management system with that. All right. All right. So any further questions at this point? All right. If there's any other questions, let me know. Otherwise, thanks for participating today and viewing these slides. If you have any other questions, let us know. Contact it here at the Expert Institute as well as these slides here.